Hello, welcome to this video on the focused abdominal sonography and trauma. This is the first part, and we're really just going to go over the technique and the basics of the FAST, and in other videos we'll actually go over the interpretation. So a couple of brief points. Remember that the FAST only identifies intraperitoneal fluid. It doesn't identify any retroperitoneal bleeding or any bowel injuries per se. But when you do have a positive FAST in a hypotensive patient, that really expedites their care because they're going to go straight to the OR. Now we'll actually also cover the extended FAST, which extends the FAST to the thoracic components. So we actually look for pneumothorax as well as pleural effusion or hemothorax. And like any ultrasound application, it depends on the operator's experience as well as the context and the pretest probability of disease. Now before we start, let's look at three common artifacts to abdominal and thoracic ultrasound. The first is bone and stone shadowing or attenuation artifact. The second is air and bowel gas shadowing or shielding effect. And the third artifact is reverberation artifact, which has to do more with the thoracic components of the FAST. So for shadowing or attenuation artifact to occur, you need to have something really dense. This is this gallstone right here. And you can see that on the anterior rim of it, it's pretty bright white or hyperechoic, and we don't actually see the bottom part of it. And the reason is because the sound waves are coming from the top and they're reflecting off of this very dense gallstone, but because of the density, there's really no sound waves that penetrate. Same thing happens here, but this is actually a rib, so this is bone right here, very hyperechoic, but then deep to that, you have this shadowing or attenuation artifact. And the problem here is that you actually don't see what you need to see, which is this hepatorenal space right here. So you definitely don't want to have this shadowing artifact when you're doing a FAST. So this is an image where you have both. You have actually rib shadowing up here, and then you have a big gallstone with some sludge in a very dilated gallbladder right here. The next artifact on ultrasound that you really need to recognize stone cold is air artifact or air shielding. And what happens here is that you have air right here and the sound waves will go right through the air and they'll scatter, but none of those sound waves will actually come back, or very few will come back. And so you get like this shielding effect where you have bright white hyperechoic air and everything is dark. So this is characteristic of bowel. And then also here in your traditional right upper quadrant view where you see liver, but then you see this very bright, crinkly type of appearance. And the key to getting rid of that is that we know that air is anterior. So all you have to do is just either point the probe a little bit more posteriorly or slide the probe posteriorly. Now if we're doing something like aortic ultrasound, you can actually compress the bowel gas and you can push those bowel loops out of the way so you can see the aorta. The last artifact that you really need to know is reverberation artifact. And how this works is that you need some sort of bright reflector. That just means that there are two types of structures that are close to each other. One is very dense, the other one is not so dense. And when the ultrasound wave encounters something like this, it'll actually reflect off of something that's really dense and bounce right back to the probe and continue to ricochet, kind of like a ping pong match. And so in terms of thoracic ultrasound, you have skin, you have your subcu tissue, and then your muscle, but then you have your pleura right here, and then deep to that you just have air from your hemothorax. And so the first time that the sound wave encounters the pleura, it'll bounce back and it'll create this image right here. This is just the pleural interface. But then some of those sound waves that hit the probe will actually ricochet back to the pleura a second time and bounce right back. Now the machine doesn't know what's going on. It doesn't know that it's just a ricochet or a reverberation artifact. It just thinks that it's encountered another structure that is pretty similar to the first structure, but because it took twice as long to come back, it must be twice as deep. So then you get this right here, and then so on and so on. The key to recognizing this is that you have these structures that look similar and they're equally spaced apart, and what you'll also notice is that they appear to dim as you go deeper, and this is due to some attenuation as well. So these, in terms of the pleura, these are called A-lines and they're completely normal. Now, same thing happens, but in a different way to your mirror image. So instead of having the pleura to reflect your sound waves off, you have the diaphragm. And we know that there is air above the diaphragm in the hemothorax. So what happens with your ultrasound wave is that it goes to your diaphragm, comes back, gets translated as this image of your spleen or your liver, and then some of those sound waves will bounce right back to the diaphragm and bounce right back again. And then what you get is this mirror image of the liver or spleen on the other side of the diaphragm. It's not real, and you really have to recognize that it's a mirror image, and the mirror image is completely normal. Now, we talked about those three artifacts. There are two aspects to knobology that you really need to know and master, especially as it relates to the FAST exam. The first is just the depth settings. So when you change a depth, you actually tell the machine that you are going to focus your attention on a certain structure at a certain depth. And by doing that, you actually increase the resolution, both temporally and spatially, of the image. And this is really important, and I'll give you a good example of that in a second. You also need to know how to manipulate the gain. And what gain does is that it actually increases the intensity of the image, or the brightness of the image, but this is actually after the echo has come back to the probe. So this is like post-processing. This is like, your Photoshop of your original image. And the key to that is that you need a good image to begin with before you rely on the gain, because the gain really will increase both the signal, the good parts of the image, as well as the bad. So the first is the depth. So this is actually a AAA. This is the vertebral body. Do you notice that right here, it says 20? This means that the machine is set at 20 centimeters of depth. And so you're telling the machine that you care about this right here, when you really don't care about this at all. You care about the AAA. So in order to adjust the depth, you usually have a couple of buttons right here. This is to decrease depth, this is to increase depth. And when you actually decrease the depth to 10 centimeters, you can see that you see a lot more detail. And this detail shows you that you actually have an intramural thrombus, and then also some hematoma right here. So very important to adjust the depth to just focus on the structure of interest. So you can see that this image, there is a pretty good window to begin with. Like, you have rib shadowing right here and here. You have part of the liver, your paranephric fat, and your kidney right here. What you don't see well is the texture of the liver or any of the structures internal to the kidney itself. And so this is a poorly gained image. In order to manipulate the gain, different machines come with different knobs and buttons, but realize that there is usually a near gain, which will adjust the gain or the brightness of the top of the part of the screen. And then there's a far gain right here, which will adjust the image brightness at the bottom part of the screen. And in between, there's also an overall gain, so you can actually increase the overall brightness of the image. Now, if you get lost, if you're messing around with the gain settings, which I totally recommend that you do to just when you're starting out, you can always rely on this backup button. This is the auto gain, and what it'll do is it'll actually revert back to the default settings. So by adjusting the gain, you can see this image right here. This isn't exactly the same image, but you get the point where you can see the liver in much more detail. You can see the paranephric fat. You can see the cortex of the kidney, the renal pyramids, the calyces, and the renal pelvis very well, even the psoas muscle. In terms of probe selection, there are two probes that you can typically use, the cardiac or phase array or the curvilinear or abdominal probe. I tend to prefer this because you can go through ribs really well because of the small footprint. But some people do prefer this, and it is a little bit more comfortable when you're doing like something like an aortic ultrasound using this because of the larger footprint. And we know that pressure is force divided by area, so if you have a larger footprint there with the same amount of force, you have much less pressure on the patient. So I prefer this for AAAs, but typically this for most other abdominal imaging. So these are the four basic windows to the FAST exam. You have your right upper quadrant, your left upper quadrant, and notice that you actually point the indicator dot, which is this right here, to the top of the patient's head, and you'll get coronal shots of both the hepatorenal and the splenorenal space. And then you can go to the cardiac and suprapubic views, and these views you actually will point to the patient's right with the indicator dot, and then you'll shoot through the liver to the pericardium for your pericardial window, and then you'll shoot anterior posterior through the bladder to look for any pelvic free fluid. And in terms of extending the FAST to the thoracic component, you will point the probe with the indicator dot to the patient's head to look for a pneumothorax, usually in the second intercostal space, about the mid-clavicular line, because that's usually where air gathers in a supine patient with a pneumothorax. And then in terms of looking for a hemothorax or pleural effusion, all you need to do is actually just angle your probe a little bit towards the patient's head or shoulder, and then slide one intercostal space above, and you'll get the diaphragmatic views for both hemothorax and pleural effusion. So this is the right per quadrant view. We're going to put the probe in a coronal fashion with the indicator dot pointed to the patient's head, and probably about the mid-axillary or posterior axillary line. And then you get this image right here where this isn't anterior and this isn't posterior, but this is actually lateral and this is medial, and this points towards the patient's head and this towards the patient's feet. So when you actually image, you're shooting sound waves actually through the liver first, then to the kidney right here, and then you go through to the iliopsoas, which is seen right here, and then more medial to that, you actually have the vertebral bodies. So the key thing in terms of the right per quadrant is that you're looking at that space, that potential space between the liver and the kidney, Morrison's pouch or the hepatorenal space. And on ultrasound, it's seen as this separation of the liver and kidney just above the perinephric fat, which is bright white. The other thing that you see is the diaphragm. So the diaphragm is up here, and because the indicator dot points up, the diaphragm will be right here. And so this is really important when you're looking for pleural effusion or hemothorax. And I'll get to that in a second. The last are the vertebral bodies right here, which kind of look like humps or like ridges that are deep to all the other structures. So one of the first things that you'll encounter in the FAST exam is rib shadowing. And again, rib shadowing looks like this. You have bright white and a hypoechoic or anechoic region that is just deep to the rib. And how you get rid of that is you actually just slide the probe either inferiorly or superiorly so that you are in an intercostal space above or below that rib. So it's just nice and easy, inferior, superior sliding. Next, you sometimes are in the right intercostal space, but you have ribs that are just above and below, and they seem to be pretty narrow and they obscure your view. And this actually is more of a problem with like our smaller petite patients because their ribs are so close to each other. And so a really easy trick to maximizing your window by spreading the ribs out is to actually rotate your indicator dot towards the patient's bed. And when you do that, you'll see that the rib spaces will actually open up and you could see more without rib shadowing. So rotate the indicator dot to the patient's bed and you'll see that the rib shadowing will actually spread out. Now you can definitely get air artifacts, and again air will look like this, which is bright white and crinkly. You'll see sometimes liver or spleen up above, and then all this is just bright white. And you know that that's air artifact, and in order to get rid of that, again, you just want to either tilt the probe a little bit more posteriorly or actually slide down posteriorly. So once you get a really good right per quadrant view, you're going to look at that hepatorenal space. So this bright white line is the perinephric fat, and then just above it should be the potential space where you should see free fluid. And in this view right here, you don't see any free fluid, but in this FAST right here, you could see that there's free fluid above that perinephric fat. So this is a positive FAST, and this is a negative FAST. The left upper quadrant view is actually the most difficult in all the FAST windows, and the reason is because with the liver, the right upper quadrant, you have this big liver that allows multiple windows to image through to the Morson's pouch right here. Whereas with the spleen, you actually have a little tiny organ for imaging through the spleen to the kidney. And then on top of that, you have stomach usually right here, and then your transverse and then descending colon about here as well. So you have multiple windows for air artifact to exist. And what you really need is to have this nice spleen where you have the lateral part of the spleen and the medial aspect of the spleen, and it should look like a tongue sticking out at you. And so this is spleen, this is kidney, this is the iliopsoas right here, and you have that splenorenal recess or potential space. You have your diaphragm above here and here, and then you have your vertebral bodies again that look like a series of arches or humps. So oftentimes when you're obtaining your left upper quadrant view, you actually need to go a little bit more superior and posterior than your right upper quadrant view. And sometimes you go a little bit too high, and when you go a little bit too high, you actually start to image the pleura. Remember the pleura, it's usually a horizontal bright white line with reverberation artifact right here. So these are A lines right here and over here. So when you see that, you know that you're a little bit too superior and you need to slide down a little bit more. So when you slide inferiorly, you're able to see the diaphragm as well as your splenorenal window. So you have stomach sabotage on the left side, and what this is that you image through the spleen, but instead of going through the entire spleen, you start to hit the inferior aspects of the stomach. Now when this is air, this will get that air artifact, but when the stomach is actually filled with fluid, you can see that this may be a false positive for free fluid when it's actually just stomach fluid. And so when you see what potentially may be stomach sabotage, you just want to tilt your probe a little bit more posteriorly or slide posteriorly. And if that potential free fluid disappears when you do this, you know it was actually just the stomach. So stomach artifact with some shadowing. You can see that it basically disappears when you just tilt a little bit more posteriorly. So again, find that tongue, find that medial part of the spleen to ensure that you're actually imaging the most posterior aspects of the spleen. So again, this is that nice little tongue of the spleen right here, that medial tip of the spleen. And then this is free fluid not in the splenorenal recess or potential space, but actually underneath the diaphragm. So this is a subdiaphragmatic recess with free fluid. Now how do you obtain your diaphragm views? Remember, we're going to look at the diaphragm to look for pleural effusions or hemothorax. It's really easy. So if you actually have your right upper quadrant and left upper quadrant views, all you need to do is just tilt or angle the probe a little bit more superiorly, and you may slide up one space as well. And again, when you do that, you're able to image the diaphragm right here. So a normal diaphragm will have either liver, spleen, the diaphragm right there, your vertebral bodies, and then the mirror image on the other side of the diaphragm. And we know that this is just an artifact. Note also that the vertebral bodies end at the diaphragm. And again, this is also an artifact because we know that the person has vertebral bodies above their diaphragm. It's just because of the air in the hemothorax that doesn't allow the sound waves to actually reflect off of the vertebral bodies back to the probe, that you don't see the vertebral bodies above the diaphragm. So again, mirror image is normal, and absence of vertebral bodies above the diaphragm, which is an absent spine sign, that is completely normal. Now look at this clip right here, and you'll note the difference where basically you have diaphragm right here, you don't have a mirror image anymore, and more importantly, you could see vertebral bodies above the diaphragm. And that's because now there's fluid of some sort or some medium that allows the sound waves to actually go through the diaphragm, hit those thoracic vertebrae above the diaphragm, and come back to the machine so that you can see the thoracic vertebrae. So if you see this, this is a positive spine sign, absence of mirror image, and therefore abnormal diaphragm view. Next, the pericardial view. It's actually easier to start just a little bit right of the xiphoid process. And the reason is because you need to image through the liver to image the pericardium. And so if you just start right of the xiphoid process and get a good liver window first, oftentimes you just need to swing or angle the probe just a little bit to the left shoulder, and then you'll be able to image the pericardium pretty well. And if you need to, you can also either have the patient take a deep breath and hold it, which will drop the diaphragm and bring the pericardium a little bit closer to you, or you can slide the probe along the costal margin to the xiphoid process. And so this is what I'm talking about right here. You're able to image the liver, the right pericardium, the left pericardium, and the right side of the heart and the left side of the heart. So in terms of holding the probe, you need to actually have an overhand grip because you're underhand. So when you apply gentle pressure right here and you fan flat in order to image the pericardium, so your knuckles will not be below the probe, and therefore you won't knuckle the patient's abdomen. So again, overhand pressure, fan flat, and then use the liver as your acoustic window. What happens when you go a little bit too medial or to the left? Well, you're not going to actually image the pericardium if you're going here, and the reason is because you have stomach and transverse colon, etc. And so this is what happens right here. You get part of the liver window, but this is all stomach right here, and so your view is actually shielded and obscured by your stomach right here. And in order to fix that, you just need to slide a little bit to the right and go through the liver. So sometimes it's hard to tell if there's actually blood or free fluid in the chamber itself or in the pericardial sac. And a good way to distinguish this is by looking at that anterior annulus of the tricuspid valve and making sure it's closely opposed to the pericardium right here. And what you'll see is that it kind of looks like that annulus is actually giving a high five to the right pericardium. This is another view, and you can see that this is the annulus right here there, and it's sliding along the pericardium, so it's giving that high five right there. Now look at this view right here, so you can see that annulus trying to give a high five, but it doesn't come close to the pericardium above. So this is the patient with a pericardial effusion. Same thing here, where this is that anterior annulus of the tricuspid valve, and it doesn't come close to the pericardium. There's a little anechoic stripe between that and the pericardium above. Next, let's move on to the suprapubic view. And the key thing is that you're imaging through bowel, and then a little bit more inferior, you're going to hit bladder. But you really need to go pretty close to the pubic symphysis. So if you see pubes, that's actually a good sign. So we're just going to slide or tilt the probe much more inferiorly, and you'll see that all this air from bowel gas disappears, and you have a nice bladder right there. So what does fluid around the bladder look like? Well, normally you have bowel all around the bladder, and so bowel gives that characteristic grainy appearance, that crinkly appearance right here. And so if you don't see the actual bladder wall that's outlined by bowel, then it's a normal bladder or suprapubic view. Take a look at this positive view right here, where you can see that lateral wall really well because of this free fluid right here. So just getting a transverse view of your bladder can sometimes give you a false negative. And if you really suspect someone with, let's say, a pelvic injury from a peds versus auto mechanism, you really should do a sagittal view of the bladder. And in order to do that, you just need to rotate the probe so that the indicator is actually pointed towards the patient's head, and you just need to tilt back and forth. So here it is, pointed towards the patient's head, and then we're just going to tilt back to the right and then to the left again. Here are two examples of where a sagittal suprapubic view will increase your sensitivity. This is the one where you first start out transverse. You're not sure if there's free fluid. There may be some free fluid here, but now I'm going to rotate the indicator so it's now pointed towards the patient's head. And you get this triangular bladder, which is your sagittal view of the bladder. And now you can see that there's free fluid right here and here. This is another view of a sagittal view of the bladder, where you could see free fluid just hiding between bowel gas and loops of bowel right here. Next, we're going to go to our last view of the extended fast, which is to look for pneumothorax. And you could actually stay with either the curvilinear or phased array, or if you really want to increase sensitivity, you can switch to the linear probe right here. And this is an image of the linear probe. Notice that the footprint on the top of the screen is nice and flat compared to a phased array or curvilinear where it's much more fan-shaped. What you're going to see is rib, again that pleural interface, and when the patient takes a breath, you'll see something sliding back and forth, and it's just the visceral pleura moving against the parietal pleura. And again, you want to image at the second intercostal space at the mid-clavicular line, because that's where air is most likely going to accumulate when you have a pneumothorax. Sometimes if you have the linear probe, especially, where you have just a lot of detail in your image, and it looks nice, this is skin, this is subcutaneous fat right here, and these are muscles, pec major, pec minor, these are intercostal muscles, and there's a rib right here and a rib right here, and you could see that this will be the pleural interface itself. Really nice detail, but you really don't need it in terms of just looking for pneumothorax. So what you need to do is actually to decrease the gain, and when you decrease the gain, all of a sudden the sliding becomes more apparent. The same thing can be done when you're using the phased array probe, and you want to make sure that you decrease the depth to basically 5 centimeters, and by decreasing the gain you can see much more of the sliding. So which side has sliding, which has not sliding? So this is actually normal, and we could see on the right there's no lung sliding, so this is a pneumothorax. So that's it for this video. Remember to recognize attenuation, error, and reverberation artifact. Use the depth and gain functions to really optimize your image quality. And with the right upper quadrant, we're looking at the hepatorenal space for free fluid. Left upper quadrant, we're looking at splenorenal as well as subdiaphragmatic spaces. For the pericardial window, you really need to obtain a good liver window first. And in terms of looking for pericardial effusion, see if that tricuspid annulus high-fives the pericardium. For the suprapubic windows, make sure that you get a sagittal view if you really are worried about free fluid. And for the diaphragmatic views, remember that with an absent mirror image and a positive spine sign or vertebral bodies above the diaphragm, you're looking at pleural effusion or hemothorax. Thank you for watching this video again. Please contact us if you have any questions or comments.